required in today's era. So initially brain death was legalized in India since 1994 after the Transplantation of Human Organ Act, and after there is subsequent amendments was done in 2011 and 2014, and then there is a legislative foundation for the brain death declaration was happened and organ donation was started. So now there is a large unmet need between the organ recipient and organ donors, because the life expectancies are increasing, there are number of technologies are increasing, transplant centers are increasing, so there are many patients are in a need of organ, but they are not getting the organ. So nearly 40 to 50% of the road traffic accidents, the cause of death is usually head injury. And one study was done cross-sectional in 2018, and they found that if only 5 to 10% of all the brain dead patients were going for organ harvesting, there will be no requirement for a living person to donate organ. So what is the potential organ donor and brain death? So potential organ donor is defined by the presence of either the brain death or a catastrophic injury to the brain which could progress beyond the reversibility, and it will eventually fulfill the brain death criteria. So catastrophic injuries like road traffic accidents, spontaneous cerebral hemorrhages like intraparenchymal hemorrhage, or subarachnoid hemorrhage is more notorious and leads to brain death. Cerebral anoxia post cardiac arrest. So early identification and then optimization of the potential organ donor is a crucial step, because every potential organ management will give us a maximum number of organs if they are managed properly. Brainstem death is defined as the stage in which all the functions of brainstem has permanently and irreversibly ceased. However, the cause of irreversible coma should be established, and there are some preconditions that preconditions should be met, and there are some confounding factors that should be ruled out. So why this is very important, and this is very there is a simple topic to each and everyone should know, because there are two hospitals. One is transplant centers, that hospitals are doing transplant. There are stringent criteria for the transplant hospitals, that this much of bed requirement, this much of doctors requirement, this much of beds requirement, isolations requirement, and there is another hospital which is organ and tissue retrieval hospitals. So for organ and tissue retrieval hospital, for registration, there is requirement is only the hospital should have operation theatre, and there should be an intensive care unit with minimum of 6 beds. So if we go by this criteria, many of the hospitals fulfill this criteria.
How registration
Yes. This is if you want to
registration
ના કરી શકાય. આપણે અત્યારે રજીસ્ટર કરવું હોય તમારી હોસ્પિટલ આ સેમ વસ્તુ માટે, તો તમે એમને બી કરી શકો. અને જો ના કરવું હોય તો જ્યારે તમારી પાસે બ્રેન ડેથ પેશન્ટ આવ્યું અને તમે એવું કહો કે અમારે ઓર્ગન ડોનેશન કરાવવું છે, તો તે જો સાયમલ્ટેનિયસલી તમારું રજીસ્ટ્રેશન થઈ જાય ઓન ધ સેમ ટાઈમ, જો તમારી પાસે આ ફેસિલિટી હોય, અને તમારું નામ પોર્ટલ ઉપર ચડી જાય, જે આપણી સ્ટેટ ઓર્ગેનાઇઝેશનની જે છે એના ઉપર લખેલું હોય કે આટલી હોસ્પિટલ આ લીગલાઇઝ ટુ ડુ રિટ્રાયલ. સો એમાં each and every time there are list of hospitals are increasing. So most of the time registration done during the index retrieval organ. So there are specific organ donation criteria. So we see that liver and kidneys are donated up to 80 years of age. There are some standard criteria and there are some expanded criteria. So they are expanding the criteria to increase the amount of organ that can be transplanted. Exclusive contraindication is HIV and current neoplasm. That is also due to explain is primary brain tumor. If primary brain tumor is diagnosed by the biopsy, then also you can transplant them. This is vague criteria, but they can expand it according to the need. So what is the steps before doing any procedure?
So
before
like if you have infections also you can transplant.
Yes.
Any bad with infection
Yes.
with a coma or some
Yes.
irreversible cause, then you can.
So there are some steps for the before doing donation of any organ. So we have to do a detailed and thoroughly examination of the patient, we need to take a detailed medical history of the patient. After detailed medical history and thorough examination, there is a clinical and neurological examination. This neurological examination includes brainstem function, and after doing neurological examination, there is a apnea test. So there is a first we need to establish the irreversible cause of coma, which is supported by radiologically, and absent brainstem reflexes, and after that patient is having a positive apnea test. Then there are some preconditions that
positive apnea test.
absolutely. So then there is a preconditions met. So these are the preconditions. If these criteria are not fulfilled, you cannot proceed with the examination also. And then there is a confounding factors. Confounding factors like patient was on a sedation, patient was on a neuromuscular blocker agent. That all confounding factors are ruled out. Then we can label as a brainstem.
Certified by which doctor?
આખો તમારી પાસે પેશન્ટ આવ્યું ત્યાંથી તમે ઓર્ગન ડોનેશન કર્યું ત્યાં સુધી આખી સાયકલ સમજાય. So there is a established irreversible cause of the coma supported by radiological and appropriate history taking. Then there are some preconditions. If patient's systolic blood pressure is more than 100 with or without vasopressor, and patient's temperature is at least 36 degrees Celsius, and this is the precondition. After that, some confounding factors like neurotoxic snake bite can present as a mimics to brain death. GBS can present to mimic to brain death. Severe encephalopathy, septic or uremic or metabolic. Severe hypophosphatemia can mimic as a brain death. And some review drugs that can cause a neurological and neuromuscular function. Like there should be at least 5 times of the half-life should be gone before we start to examine a patient for a brain death. So if we have given a midazolam or a fentanyl, at least 5 half-lives should have been passed before we start the examination. Then there comes a, if all these preconditions are met, then we will start a neurological examination. So neurological examination we start with the no any spontaneous movement, no any eye opening, or any spontaneous response after verbal or visual commands. After that we give a painful noxious stimuli to the supraorbital ridge, sternal node.
Here without any sedation.
Without any sedation, there should be at least
no sedation.
At least 5 times half-life.
Sometimes patient is on ventilator and patient is sedated, is given sedation.
So that is precondition. At least 5 half-life should have been passed before we start the examination. So that we can achieve through the reviewing the drug chart of this patient. Then there is no noxious no response to noxious stimuli. Pupils are equal, fixed, dilated, midline. There is absent pupillary reflex to direct and indirect light method. No corneal reflex, no gag reflex. We can check with stimulation of the posterior pharyngeal wall. No cough reflex. We can check with introducing the suction cannula to the endotracheal tube. There is no cough reflex. Absent dole's eye reflex is also present. Then there is absent oculovestibular reflex or a cold carrying test. In that cold carrying test, we instill a 20 to 35 ml of cold ice cooled saline, and there is a no nystagmus. So this is also oculovestibular reflex. All these reflexes are examining different cranial nerves that is originated from the brainstem. So after doing all these examination, we go for the apnea testing. So once all the reflexes are tested, then there is a apnea test. Apnea test is the most important and most crucial aspect of the certifying brain. Apnea test is mandatory for the diagnosis of brainstem death, and it should be only performed when all the breathing requisitions are met and there is a thorough clinical examination of the brain reflexes done. So absent respiratory effort and there is a presence of hypercapnia is the principle of apnea test. So there is no respiratory effort and there is an increase in the PCO2. That is the basic principle of apnea test. So before we start the apnea test, there are some prerequisitions. Core temperature should be more than 36.5. Patient should have a euvolemia. Normal PCO2 before starting the apnea test. Normal PO2 before starting the apnea test. And there should be a continuous monitoring of pulse oximeter, cardiac monitor, blood pressure should be monitored continuously. So this is the steps of apnea test. So these precautions like core temperature should be 36.5 1.5 systolic blood pressure should be more than 90, fluid buoyancy, U volume should be achieved. Then after that we need to pre-oxygenate patient with the 100% FiO2 for at least 10 minutes. Then after pre-oxygenated, we will reduce the breaths to 10 mL per minute, decrease the P to the 5 of centimeter of H2O. Then we will do the ABG, first ABG. Once we do the first ABG, then the PCO2 should be more than 200 and PCO2 in the around the range of 35 to 40. If your PCO2 is less than 35, then arrange your ventilator to bring it between 35 to 40. If it is more than 40, then arrange the ventilator and bring it to the 35 to 40. But your starting point of apnea test is your PCO2 should be between 35 to 40. So once you achieve this, you disconnect the ventilator of the patient. So most of this type of patient will have a brain trauma, and they will not have a lungs are mostly not compromised. So when we disconnect the ventilator, then we will introduce the suction catheter with attached to oxygen, and suction catheter should be introduced inside the endotracheal tube, and it should reach up to the carina, and we will give at least 6 liter of oxygen via the suction catheter. So patient is receiving continuously oxygen via the suction catheter. And then we will observe the monitor also, we will observe the chest wall also, and we will observe the any movement. So we will continue this process for up to 8 minutes. So it is we do the ABG at the starting of the apnea test, and we do ABG for our convenience. We do ABG at the 4 minutes after starting of the apnea test, and after one ABG at the 8 minutes. So after there is a doing a second ABG, there is an interpretation of this apnea test, and in this interpretation, if PCO2 increases more than 20 from the baseline, so our apnea test is positive and patient is brain dead. Or patient PCO2 is more than 60, this also confined to our patient is apnea test is positive and it is a brain dead. And after that, reconnect the ventilator and you document that this our apnea test is positive. So if any spontaneous movement observed during this apnea test, we need to abandon the apnea test and we reconnect the ventilator. So if any respiratory movement are absent and PCO2 is more than 60 mmHg or any increase of the PCO2 from 20 mmHg from the baseline, our apnea test is positive. So then after we do the first clinical examination, we will wait for up to 5 to 6 hours before doing apnea test for observation time, and then we do a first apnea test. Usually consent is not necessary for carrying out the apnea test. Apnea test can be carried out by a treating physician or an intensivist in charge, and but ideally in our Indian scenario, we inform the patient that your patient before doing apnea test, also after doing all the clinical examination, our hospital or treating physician will inform the patient that we are going to do a apnea test to your patient. Consent is not required as per legal guideline. An apnea test should be done twice and it should be done 6 hours apart by the registered medical practitioner. So first apnea test will be done by ourselves, in which the hospital is in which the patient is admitted. Once the first apnea test comes positive, we will inform the transplant coordinator of our city. And after we send all the report and first apnea test, transplant coordinator will inform the SOTO organization. SOTO organization will form a committee for this specific patient, and they will send their doctor after 6 hours to again do examination of this patient. So their doctor will also come to our hospital after 6 hours, and he will also again perform apnea test in presence of us. So apnea test should be done twice. First it will be done by us. After we will do a first apnea test, then we will inform the transplant coordinator, and the particular government organization will send the certified doctor from their point of their contact, and he will do second apnea test. And after second apnea test, we will confirm the brain.
Degree is necessary, like you should be.
Yes. So if apnea test is not not if patient is on 100% FiO2, sometimes he cannot do apnea test. Then there are some brainstem examinations are not properly done or not can be done. Patient has a facial-maxillary injury and it is severe. We cannot do any reflexes. In that condition, if any of the doctors were in doubt, then they can go for an ancillary test. So ancillary test is not mandatory, but if any of the panel doctor is out, we can order ancillary test. So there are some ancillary tests, which is DSA, 4-vessel angiography, then CT angio or MR angio, then transcranial Doppler, and there is a EEG. DSA, there is a flow of DSA, CT angio and MR angio. In all these angiography ancillary tests, there is a flow up to carotid arteries. Extracranial carotid arteries, there is a flow. But when the patient's blood reaches to the extracranial artery and goes inside the cranium, there is no flow. So particularly the ICP is increasing that much that there is a complete cessation of flow inside all the circulation of brain. So that is the confirmatory test. That is not required in each and every patient, but sometimes it requires. So the diagnosis of brain death is established and recorded by the two doctors, which is not belonging to the retrieval teams and transplantation teams. That is most important. So doctors which are not included in retrieval team and transplant team. Out of the two doctors, one must be in a specialty in neurology. So most of the time, the second doctor that comes from the government, it is either a neurosurgeon or a neurophysician. Most of the time. In Ahmedabad, the government having a neurosurgeon, neurophysician also, so they send a neurosurgeon. In our SSG also there is a neurosurgery department, so they also send a neurosurgeon to do a second application. So certification, then after doing the certification of brain death requires a panel of 4 doctors. So there is a Form 10. Form 10 is a certificate that we are during the proper examination, we are doing a certificate and we are certifying this patient as a brain death. So 4 doctors' signatures are required. So doctor in charge of the patient, then doctor in charge of the hospital where the patient was treated, usually RMO or a CMD, then independent specialty of one specified specialty. So if your hospital having a 2 intensivists, so one is the doctor in charge of the patient and the third one is the second intensivist or a physician associated with the hospital, and 4th is the neurologist or neurosurgeon in your hospital, or a 4th is came from the government. So all the 4 person will sign this form and it is certified as a brain death. So after this process, patient is certified as a brain death, and we after certification of the brain death, we inform the transplant coordinator. So clinical examination and testing should be done 2 times after the interval of the 6 hours, and after the second test, counseling of the family regarding the organ donation should be done, and time of death is most important. So because patient is going to survive, patient is brain death, but his heart is working till the patient is transferred to the OT for retrieval of organ. So what is the time of death? It is so second apnea test we have done. It is the time of death that we will write on certificate. So in a newborn or infant, observation period of 24 hours is required between 2 apnea tests. In children, observation period of 12 hours is required between 2 apnea tests. In adult, observation period of at least 6 hours is required between 2 apnea tests. So all the phases of determination of brain death should be clearly documented in the medical record, like irreversibility of the coma, no motor response, no brainstem response, absence of positive apnea test, and if we have done any ancillary test, then the justification for the ancillary test. So ideally, counseling of the next of the kin should be done by the transplant coordinator, and counseling of the organ donation should be initiated by the treating, or the organ should not be initiated by the treating doctor or any organ retrieving team to prevent the conflict of interest. But in our scenario, patients are not going to listen to the transplant coordinator. So as a treating doctor, we initiate just that we can do an organ donation, and rather than going into detail of the organ donation, then we introduce the transplant coordinator, and this transplant coordinator will explain all the processes to them and convince them. After that, Form 8 needs to be filled. Form 8 is consent of the patients or patient's team, that they have given consent for the organ donation. And once the patient gives consent administrator of the hospital should be communicated and patient's billing should be stopped. After giving consent, patient's billing should be stopped. From then onwards, all the billing will be borne by the organ printer hospital. And data protection and confidentiality of the recipient is also maintained. Donor's family need not to have access to the recipient's name. So my organ is going to which patient, he is Hindu or Muslim. Some ask this question. So this should not be provided at any cost. So one is we need to take a consent. After consent, there is no charge to a patient. We can take a charge before doing the second apnea test to patient. After that, hospital cannot charge anything to patient regarding any investigation. So that is the administrating and identification and process regarding things. And this is the medical management. So once the severe brain injury happens, there is a raised ICP and a patient has we attempt to maintain the cerebral blood flow and cerebral perfusion pressure. But it is a severe injury. So once the severe injury, we cannot protect the brain. So our focus switches from the recovery of the brain to the focus switches to the maintaining of the organ preservation. So once the this cascade happens, there is a severe autonomic disturbances happens inside the brain dead organs, starting from the sympathetic stones to the complete vasoplasia to the heart rate slow, arrhythmia, patient develops hypotension, patient develops hypertension. This all happen sequentially, and this all can damage each and every organ if not managed correctly. So our intensivist job starts with this organ, this autonomic dysfunction that happens inside the body, and we try to mitigate this storm that happens inside the body and try to preserve organs that is most suitable for the transplant. So general care, it is it used to be given to each and every patient. Hand hygienic, proper position, eye care, nasogasic tube should be inserted, stress ulcer prophylaxis, deep vein thrombosis prophylaxis, pneumatic compression devices. Arterial line is must because you need to take 2 ABG simultaneously during apnea test also. So arterial line in situ will be great helpful to you because you try to puncture and take a ABG. Instead of that, before starting the apnea test, to do a arterial line insertion. That is a very helpful way. Frequent change of the position, bronchial taillet. All catheter must be quietly handled to prevent the risk. Warm blankets should be given to temperature maintained around 36.5 points. Broad spectrum antibiotics can be given according to past history of the patient. Document patient's height, weight, and chest circumference. Then this is the ideal guideline that we should monitor ABG, lactate, electrolyte, and blood sugar at least 2 to 4 hourly. This is not possible in each and every case, but you should measure at least electrolyte every 6 hourly once the brain death is declared. What are our targets of this patient? So MAP should be more than 60-65, heart rate between 60 to 180-120, CVP between 6 to 10 cm of H2O. Urine output we should maintain at least 0.5 to 2 ml per kg per hour. PO2 should be more than 100. Blood sugars are in the range of 120 to 180. Hemoglobin more than 7. Hematocrit more than 30%. Sodium is most crucial and most important ion, most important electrolyte. Sodium should be between 135 to 155 even before we do the apnea test. So if your sodium is 165, you cannot do apnea test. So the sodium should be between 135 to 155. Management of the hemodynamics. So there is a sympathetic stones that happens after brain death. It will lead to arrhythmia, myocardial infarction. Then there is a severe vasoplasia because loss of all the spinal reflexes, vasodilatation leads to hypotension. So our goal is to maintain the normovolemia, mean arterial pressure of 60 to 65, and optimize the cardiac output. We can use bedside cardiac echo, IVC, and dynamic variable to judge the fluid responsiveness. Isotonic crystalloids with balanced salt solution is preferred. Colloids are avoided. 20% albumin is given if we are going to transfuse a lot of amount of fluid. RBC to maintain the hematocrit more than 30%. If patient having a vasodilatory shock, then first choice of vasopressor is vasopressin as a 1 to 2 unit per hour. use of vasopressin also counteract the diabetes, central diabetes insipidus, also restores the vascular tone and reduce the other catecholamine vasopressor that will hamper the organs. Respiratory management is like simple. We are doing day in day out because many patients will have a trauma to the chest. Also, many patients can have a aspiration pneumonia. Many patients can have a secondary ventilator associated pneumonia. So, at least 6 to 8 ml per kg of tidal volume with predicted body weight. PEP is equal to 8 to 10. Closed circuit for tracheal suction. Alveolar recruitment can be done after disconnection of the ventilator, and we can use CPAP during the apnea test. Respiratory target is same. pH should be 7.35 to 7.45. PO2 more than 100. Oxygen saturation more than 95, and PCO2 between 35 to 40. That is our ideal target. Another very important thing that happens in brain death is endocrine dysfunction. So, hypothalamus pituitary axis got affected. Almost all the patients having a dysfunction of posterior pituitary and will have a diabetes insipidus, central diabetes insipidus. So, I have seen diabetes insipidus in all the patients of brain death I have seen. All the brain death patients, they have a diabetes insipidus in any point of time after the diagnosis of brain death. So, deficiency of antidiabetic, it happens with the સવાર સુધી 50-50 સુઈને આવતું હતું અને બપોર 2 વાગ્યા પછી એકદમથી 200-300 પર અવર યુરિન આવવાનું ચાલુ થયું. એટલે હું રજિસ્ટર હતો તો અમે લોકો ખુશ થઈ જાય કે અમને લોકોને એવું લાગે કે યુરિન આવે તો એમાં સારું કહેવાય એમ. તો પછી આવી રીતે એક વખત ફોન કર્યો કે નાઉ ધીસ પેશન્ટ ઇઝ હેવિંગ અ lot of amount of urine. પછી then retrospectively we understand that this is happening due to this and patient is actually getting worsen and we need to aggressively manage this. So this causes hypovolemia. So initially we should to manage the hypovolemia with the balanced salt solution, and then we need to do the replacement fluid with the 0.45 half normal saline or dextrose 5%. If patient is having a diabetes insipidus and we having hypotension, we start the vasopressin infusion as a 0.5 to 2 unit per hour, and it works wonders. When you have a diabetes insipidus and hypotension, you start a 2 unit or 1.2 unit per hour of vasopressin. Patient's blood pressure also restores, and slowly his urine output also going to decline. Or if patient is not having hypotension, we can give a desmopressin. It is a specific B2 receptor agonist. It is given as a 1 to 2 dose in a 1 to 4 microgram. It also comes in a nasal spray. It is very difficult to obtain, but it also comes in a nasal spray, and tablet is also available. So you give a 1 tablet or 1 puff of desmopressin. Then you observe for 6 hours for the urine output. Patient's urine output will suddenly drop to 300, 350 to 50 to 100. And after 6 hours, again patient urine output is going to increase. Then you give a second dose of desmopressin to this patient. And target sodium should be between 135 to 150. Corticosteroid deficiency can also happen. So each and every patient will require a 50 milligram per kg of methylprednisolone after the diagnosis of brain death. So when you do a second apnea test, each and every patient of brain death will require a 50 milligram per kg of methylprednisolone. It will also help in immune modulation, and it will also help in some on the other way during the organ transplantation with the recipient also. So that is the each and every patient, and it's repeated every 24 hourly till the organs are retried. Insulin infusion should also be given to maintain the sugar between 140 to 180 or 80 to 150. Another more important thing is thyroid hormone replacement. Almost all the West guidelines are giving intravenous
management of hypopituitary. In short, you are telling
because all the patients will have a hyperglycemia also. Due to this, we are transfusing D5 for diabetes insipidus or a patient having a stress response, so insulin should be given. And all the West will have a intravenous T3, but we are not having intravenous T3 available now. Our is possible. So 300 to 400 micrograms of our oral 3-4 every 8 hourly should be given by our national guideline in a patient to prevent hemodynamic instability and cardiovascular. hypothermia is also a very common thing we encounter in brain death because all the protective reflexes are when shivering is when patient is not going to have a protective mechanism against hypothermia. So hypothermia is bound to happen, and hypothermia happens, it will also cascade another problem like metabolic acidosis, coagulopathy. So you can rewarm the patient by temperature, lactates or fluid warmers. You can give a warm saline by an nasogastric tube also to bring the keep the temperature between 35 to 36. Anemia, coagulopathy and immunological changes can also happen, and continue enteral nutrition till the patient is shifted to the operation theatre, because enteral nutrition will maintain the integrity of the our gut and it will prevent the translocation of the bacteria. Infection management. So severe brain damage and cerebral health predisposed to infection due to heavy impairment of the cellular immune systems, and there is immunity instability. There is a bacterial translocation from the bowel. So prevention is the most important thing. Use of closed suction, good nursing care of all the indwelling lines and Foley's catheter and ventilator and atopic hand and bacteremia and sepsis is not a contraindication to donation, provided we have a identification of the bacteria and provided the recipient donor have received antibiotic for 48 hours and the recipient who are going to receive that organ, that recipient also required to get that antibiotic for at least 7 to 10 days. So bacteremia and sepsis are not contraindicated. But if you have any encephalitis or a meningitis without any identified bacteria, or a flaccid paraplegia of unknown cause, or there is a poliomeningitis and rabies or HIV, these are the contraindications. So disseminated candidiasis, fungal infection is also not contraindicated, but provided you give an antibiotic to the 48 hours to the donor and 7 to 10 days to the recipient also. So take up home messages. Early identification of the potential brain organ donor is the key in the whole chain of organ transplantation. So you need to identify that this patient can become a potential organ donor. Then after identification of the potential organ donor, you require multimodal management of all these things because it is a catastrophic event. When it happens, there is nothing you can handle if you have not acted properly, and you will lose the potential organ donor. Community support, awareness in community, effective collaboration with the NGO, transplant coordinator and SOTO, and proper documentation of the hurdles during the process can increase the number of potential organ donors. So if we have a brain death patient and his families are not agree for the organ donation, so if we try to document that and provide it to the government that these are the reasons relatives are not willing to donate, so they can do something to prevent that hurdles also. So all these things as a collaborative effect will increase the organs and donate organs and save life, or BCCI also says donate organs and save life.
See, how long will you prolong this management? There sometimes see there are issues. Patients are in confused state. Some the festival going on, and your administrative organization split away. So how will you suppose there is some patient relatives who say they will donate, but still they do not give you consent.
Yes,
Now, at the same time there is a festivity going on. And how long will you continue this kind of management?
So there was a study, some Muslim countries don't promote organ donation due to some religious things. So in that state, they have done a study. After declaration of brain death, median time of survival was 6 to 7 days. 6 to 7 days patient survived without any compromise. Then once a point of time, even you do everything, patient's heart is going to stop. But no patient was survived more than 30 days. That was they have done a study. But 5 to 7 days they have tried to make this patient happy. But once
नहीं पण 7 દિવસ સુધી maximum
maximum कोई rule, maximum कोई rule.
There is no
But
lingering.
patient will go there by naturally, because once the 48 hours will pass, patient will try to accumulate fluid. Once patient will try to accumulate fluid, then will get basically he is going into septic shock or something infection. That will again will lead to the hypotension, and once there is a hypotension and there are specific amount of vasopressors and iron drops are required, then your patient is out of question of donor. That this much amount of vasopressor is not should not be given for longer period of time.
Maybe one more question like comes to me is like legal issue. For example, we have done a apnea test
Yes, sir.
and both apnea test is positive.
Positive, yes.
Now we are informing the relative. Relative says, "Na, मार तो घरे નથી લઈ જવાનું, કશું મૂકી રાખો." Now the patient is not ready for a transplant now. So what is the hospital billing? That is one. And second thing, what about mercy killing? Sometimes patient will say કે સાહેબ હવે કશું થયું નથી. તો એને મરવા દો ને હવે કંઈ કરી કાઢો કે છોડી દો એને. Like so,
In India, legally you can already remove the ventilator after certification of brain. In any another patient, you cannot remove ventilator in India as per law.
you can remove the ventilator if patient relative agree.
If
After
after
two
two
appointment
days,
certificate.
you can remove the ventilator if patient relative agree and not willing for donation. That is one. In any situation, you cannot remove the ventilator by law in India. That is, you are not going to have a good thing.
But it makes
for
you
the-
mercy killing only.
Yeah.
Almost like
But-
patient relative will not agree.
But
Donate
you have certified brain death,
very lazy.
then you can remove the ventilator. But
ઘરે
without
વેન્ટિલેટર સાથે
certifying
લઈ
brain
જવાનું
death,
કે વેન્ટિલેટર ત્યાં જઈને કાઢવાનું બીજું તો હું
without certifying brain death, you
That is
cannot
what
remove
usually we are doing.
endotracheal tube in your hospital. Without certifying brain death, you cannot remove endotracheal tube in your hospital. And billing is, patient is not giving consent for the organ donation. So billing is, he is going to. So billing is only stopped after giving consent for the organ.
So who will give the bill after that?
So
Usually
usually
government
government will give the,
government
we have to give a proper amount of bill to the hospital. We made a bill and we give to the government, and if the bill is more than expected, then the bill is also split between the recipient also sometimes. Because some, you have seen that some came from their ambulance. So all that air ambulance and all cost borne by the recipient only. So government gives around 1 lakh rupee to hospital to manage the patient. 1 lakh per patient, 50,000 they will immediately transfer to your account. Once you certify them, 50,000 they will immediately transfer to your hospital. And after
ટેસ્ટ
giving,
કરો ને એટલે કોઓર્ડિનેટર જે હોય છે ને સોટાનો કોઓર્ડિનેટર અહીંયા રિકમેન્ડ
રેલવે હોસ્પિટલમાં છે આપણે
વેરી ગુડ લેવી અને બધું આખું હેન્ડવર્ક ઇન્ક્લુડિંગ પેશન્ટ મોટી હોસ્પિટલ આખું એ લોકો લે
Green corridor ને બધું જે બનાવો છે, that will be done by the coordinator.
coordinator,
કોઓર્ડિનેટર એક્સપર્ટ હોય
they are very
વેરી
they
એક્ટિવ
help you to procure everything legal procedure also.
આ એ પહેલા એક
80
સ્લાઇડમાં
years.
આવ્યું
80 years. So kidney and liver are transplanted up to 8 years, and if patient is less than 40 years, then for liver is in good condition, they can transplant liver to the two recipient also. Split liver transplant, they can also do patient.
Very good, very good.